So my name's Andrew, I'm convener for Ambulance Q, and we're here to, the aim of today is to share information around health inequalities across the ambulance sector, and also to get people thinking and talking about the subject. Today we're just going to do a quick check-in, find out where people are today, and look to see how we are going. We've got Christine and Ruth looking to set the scene, and then we're just going to be able to share some examples from across the UK in relation to activity that people are already doing that might get your thoughts, you thinking. And then actually we're going to go into breakout rooms and ask you 3 simple questions, and then we'll come back and finish up. So just gonna use some of the annotations within Zoom. It's been a while, but so what we're going to do is we've got a map that's disappeared. Okay, no, we've got the map there. So what I want to do is up the top, if you go on to click on annotate, or it might be down the bottom of the screen. So if you click on annotate and then choose a stamp or a drawing, and we're just wondering where people are today. So you can just draw a circle around where you are in the country. You can use text or a stamp. So if you find the annotation button and click on the map where you are,
it's in view options if anyone can't spot it. A menu called view option.
It can get quite interesting, but we'll just leave it here for a minute.
Sorry, where did you say it was?
So if you go to view options, annotate, and then there's a bar that comes up, and you'll be able to press stamp. That's probably the easiest way to do it.
Yeah, if you move, so as you move your mouse cursor up to the top, the little view option kind of menu should appear, and you click on that to get to annotate.
And if you're not in the UK, you can go to the far right or use the text and say where you are in the world. So we've got a good spread of people. You can always, if you're having some challenges, you can always type in the chat as well. So we've got a number of people from across the UK who are going to share their stories today, but I'm going to start with Dave, who's from North East Ambulance Service. I'm just going to clear all these drawings, because actually as I move on, I think I'll... So if you stop annotating now, and I've cleared all of those, and I'm just going to pass over to Dave. He's going to tell you all about a bit about Ambulance Q.
Yeah, morning, Andrew. Good morning, everybody. Actually, I was quite enjoying that, Andrew. I thought that was, it took me about 5 minutes to work out what I was going to use, and Marcus is back again now with his, I don't know, this hangman or not, I'm not sure. So, as Andrew has introduced, we are a smallish in number special interest group who sit in the sort of umbrella of the Health Foundation, which I believe we've also very lucky to have Matthew on here today with some support. It was established back in 2017 with Andrew and one of our colleagues who at the time was working for in Northern Ireland Ambulance Service, and it started to sort of grow steadily and slowly through to sort of 2018. And we had some input from NHS Horizons, and there was a big piece of work to try and get ambulance services working together and having those people in the roles that they do, being the ones that are the innovators and the sharers and the networkers, etc. Obviously, we don't need to explain what happened over the last couple of years, which obviously has taken a big hit. We were very lucky to be successful in a bid for some funding to take Ambulance Q to the next step, which this is now the first part of that, now that we're back to some form of sort of normality. And it's just really around how we can have support, how we can get staff to be involved a little bit more in the world of improvement, or probably more so just getting people talking about improvement, getting people sharing, getting people learning from what other trusts have done, be that ambulance trusts, be that acute trusts, be that primary care, etc. And it's that sort of relationship side and that informal network that that we believe is our strength. It may not be that Andrew and I speak regularly, but it may not be that we are after anything specific. It might just be a checkup. It might just be to run something by. If Scotland have had some experience, or our colleagues in Wales or Northwest have done something, and if we don't necessarily know the answer, generally we always know somebody that we can connect to. And I think that bottom point that Andrew's put on there around the super connectors, that is the strength of what we do. As I said, we might not have all of the answers every single time, but generally we'll know that actually it may not be Andrew that you need to speak to in Scotland. It may be Lauren that you need to go and speak to. So it's just around connecting and around building those relationships. And it's so much easier just to have that quick phone call or quick email or text to somebody that you know around the country, rather than trying to spend hours and hours and hours looking for something that probably has already been done. So it is just around that connecting. And I think, Andrew, the last slide it's just about how we can make things easier, make things smarter, make things more accessible across whatever it is that we're looking at, be that around inequalities, which is what we're talking about today. So there is a bit of an ask. We are actively looking to get more people involved, and the more we have involved, the more that we can do, and the further we can reach out. And I'm sure these will be sent around afterwards. But if you are interested in joining our little small group, which hopefully will become bigger from today, then there's some links on there. I'm sure Matthew can put them in the chat as well, but they'll also be shared, I believe, Andrew, after this presentation. So I hope you enjoy this morning, and we look forward to seeing more of you as we go on. Thanks, Andrew.
Thanks, Dave. And I'm going to hand over to Christine Camacho from Northwest Ambulance Service to take us through the next section.
Morning, everyone, and thank you for having me here today. And sorry if I accidentally scribbled on your slides then, Dave. If that was me, it was completely accidental. So I'm going to talk a little bit about health inequalities today. So I'm a public health registrar working at the Northwest Ambulance Service, which is quite an unusual place to be for a public health registrar. So we would usually be found in local authorities and public health organisations. So it's been a really interesting experience and journey over the last couple of years. I'm going to start off just by talking a little bit about what health inequalities are. So health inequalities are, just want to move the slide on for me, please, Andy. Thank you. Unjust and avoidable differences in people's health. And there's lots of things that shape those health inequalities. So a lot of it is actually determined by where you live, the environment that you grow up in, your employment opportunities, etc. And just to give some kind of examples of some of that, so for people experiencing homelessness, the average age of death is 44 years. And that's compared to 83 years for men and 86 years for women in England. So people born in the most deprived areas in England have a healthy life expectancy of 51 years compared to 71 years in the least deprived areas. And if you think that the state pension age is currently 68, there's a whole cohort of people who won't actually be healthy enough to continue working until that age. So amongst asylum seekers, 61% are likely to experience serious mental health problems, which is 5 times more than the general population. And when we think about COVID and what happened during the first wave of COVID, the death rate in Black men was 257 deaths per 100,000 of the population.
Okay, so he's just done the test. He's not done the
70 deaths in white men. So clear inequalities there by ethnicity. And if we think about mental ill health, people with a serious mental illness are more than 3 times likely to die young than those without a serious mental illness. So they're just examples of some of the health inequalities that we know about. And if we want to think about the causes of those health inequalities, healthcare only contributes to about 20% of health inequalities. The other 80% is what we'd call wider determinants of health. So health behaviours and the environmental stuff, education, employment, the things that I mentioned before. Okay, so going on to thinking about addressing health inequalities. So we can't just treat everyone the same and assume that everyone will benefit equally. And I was having a conversation a few months back with someone in our organisation about ethnicity data. And this is a conversation I have quite regularly because whenever I've tried to use the ethnicity data that's collected in our 999 service, it hasn't been possible to do that because so much of it has been missing. And so I was talking about, what can we do to try and improve this data? And this individual turned around and said to me, but why do we need to collect ethnicity data? We treat everyone the same. It doesn't matter. We don't need to know. And we do need to know. And unless we actually collect that data and look for those inequalities, we won't know they're there. So there may be situations in that middle picture around equity where we actually need to do something different for certain groups of people so that they're not disadvantaged. And justice in that final picture refers to a situation where those causes of causes, if you like, that Professor Michael Marmot talks about are removed through removing some of those wider causes of inequalities. And I just want to give you a couple of examples of why this is important. So if you can just move forward one, Andy, for me. So thinking about deprivation. So what this graph is showing you, this is an analysis of our 999 data based on the deprivation level of where people live. So this is split into 5 groups, so quintiles. Quintile 1 is the most deprived areas and quintile 5 is the least deprived areas. So what we observed when we looked at this data, and we've never looked at this as an organisation before, is that deprivation is really driving our activity. So the people living in our most deprived areas have, not quite, but almost double the rate of the 999 incidents than the least deprived areas. So it's a really important driver for demand. And it isn't something that's actually explicitly taken into account in how we're funded as an organisation. So if you just click on for me, and again, thank you. So this is just a little bit of modelling around that, because in the Northwest, we're actually more deprived than England as a whole. So if our level of deprivation was the same as England, if you like, that would equate to roughly 85,000 fewer 999 incidents in a year. And if we were able to level up, so you'll hear the government talking a lot about levelling up, what that means in practice, I'm not quite sure, that if we were able to do that, and across our whole population, we have the same rate of incidence that we do in the quintile 3, that middle quintile, we'd have 135,000 fewer incidents in a year. So deprivation is really important. Next slide, please, Andy. So this is another example here around mental health. And just to emphasize that if you don't look for it, you're not necessarily going to find it. So last year we had some serious incidents in relation to long waits for mental health. And on the back of that, actually looked at our data around mental health long waits and physical health long waits. And the key message from this slide, so there's a lot of numbers on there, but basically across every category of call, if it's a mental health call, you're more likely to have a long wait across every category of call compared to a physical health call. And that was really important for us as an organisation in understanding that actually we're not delivering parity of esteem between mental health and physical health presentations. And in that, as an organisation, we're actually kind of generating, if you like, our own inequalities in how we're responding to those calls. And so that's now a piece of work that's kind of monitored in the organisation and being taken forward to address that. Okay, next slide, please. So why is it important for us, and why are we well positioned to do this? So we have a huge volume of face-to-face contacts as ambulance trusts and regional providers, and the data that's generated from that is vast. So you know, actually understanding where those incidents take place. So we know about violence, we know about cardiac arrest, we know about strokes. It's just a wealth of place-based data. And actually, when you start to talk to other public health people in the system, they're astounded and excited by all of this data that we have in ambulance trusts and the potential for understanding more about the health of the population. So lots of established relationships with other providers and really acting as a safety net to the rest of the system. So really good at showing where those gaps are, be that around end of life care or particular groups of people. Okay, if you could move on, please, that'd be great. Thank you. So this is something from a national document that Ruth and Sandra, who are on the call today, produced, thinking about how public health approaches also fit with quality improvement. So starting that journey with data and understanding what's important, and leading that through to using quality improvement methodologies to actually test changes and evaluate that. So I'd encourage you to look at that document, because there's a wealth of really useful information in there, and I'll post the link in the chat afterwards as well. And next, I'd like to show you a driver diagram that my colleague Kate put together around the work that we're doing in the North West Ambulance Service around some of this. So starting with the 4 chunks of our public health plan, which are around strategy, data and intelligence, capability and supporting delivery. Going on to talk in the blue section some of the specific items in our plan, and then thinking about, well, what and how's that leading us to what we want to do around reducing inequalities, but also linking that to, this is in terms of how do we use our resources better, how do we think about managing our demand. These things all linked and part of the same story. Next slide, please. So we've talked a bit about health inequalities and what they are. We talked about the 20% in healthcare and the 80% that are the social determinants, if you like. And I'm just going to really briefly introduce two frameworks for thinking about how to address those. So the Core 20+5 framework was released from NHS England last year, and that really talks very well to those healthcare inequalities. And then you've got thinking about the NHS as an anchor institution, which talks more to those wider social determinants. So if you can just flick on for me, please. So this is thinking about NHS, so it's thinking about NWAS as an anchor institution, and we held a kind of a mapping workshop, if you like, to think about the work that we already have going on. And the 5 kind of blobs in there are the 5 pillars from the Health Foundation in terms of what anchor institutions do. And this is all about social value. It's about what we can give back into our local population. So lots of examples of working in partnership, thinking about carbon literacy and our green planning. A lot of work going on around widening access. So apprenticeships, how we work with people who've been long-term unemployed. We've got programs in terms of ex-veterans, all sorts of things around that. Thinking about how we can give back a social value in terms of our procurement. So what contracts, wherever possible, will be given locally within the Northwest. And then thinking about our fleets and our vehicles and what we can do around working towards the carbon zero agenda. And moving on, I'll just touch on Core 20+5 briefly, hopefully before my voice runs out. So Core 20+5, so the Core 20 bit refers to the 20% of the population living in the most deprived areas. Now in the Northwest, that's closer to 1/3 of our population, and that will be similar for the Northeast as well. But some areas they will have less than 20%. The plus part refers to particular groups that we might be interested in, and there's some suggestions there for the ambulance sector about what that might be. So high intensity users will be a group of people who, again, will experience lots of health inequalities. The people experiencing homelessness, alcohol and substance misuse, and learning disability and autism. But you may think about more groups within your organisations that you want to focus on. And then the 5 touches on 5 clinical areas of health inequalities. And we've started to think about what that means for us. So within maternity, we deliver roughly the same number of babies as a small maternity unit. And we think we probably care for quite a vulnerable cohort of women there. So thinking about what we could do perhaps in terms of continuity of care for those women. We talked about mental illness before, thinking about could we do something to support those health checks for people with severe mental illness. We'll probably already be taking a blood pressure reading, for example. What else could we do around that cohort? Under like chronic respiratory disease, so is there anything we could do to perhaps extend home oximetry that started to be rolled out as part of COVID to people with other breathing difficulties, etc. And I'll talk a little bit later around hypertension case finding as well. So these are just some examples really of how we've started to think about and interpret that framework. And I'm going to stop there and hand over to Ruth, who will talk a bit more about the national context. And I don't know if we're stopping for questions now, Andy, or whether you want to do that after Ruth's presentation.
There is a question in the chat. We can stop for questions just quickly from that and then go on to Ruth.
Sure. I haven't been looking at the chat. I apologise.
No, it's fine. So it's just, there was a question in relation to the data from Anne around the 999 data as open access. Anne, do you want to expand on that?
Hi, Christine.
Hiya.
Thank you for a really interesting talk. I was just wondering if the data that you presented is something that we can have a look at as well, just to do further analysis on, or just explore a bit further, basically.
That particular data was kind of from the Northwest Ambulance Service. And that part of it wouldn't be open access because I had the postcodes of all of those incidents and used the postcodes to link to deprivation, if you like. So that particular data wouldn't be in the public domain. That analysed bit, the graph that I showed there, absolutely you can take that and use that. So it's something that ambulance trusts themselves would be able to do. They'd be able to look at their own data and do that. But I don't think that data is available in an open source in a way that it would enable you to link it to deprivation. But others may know differently and may want to say something different.
Thank you.
Thanks, Anne. Thanks, Christine. I'll hand over to Ruth.
Thank you.
Thank you very much. So Christine's just done a really great job, I think, at describing why this is so relevant to the ambulance sector. So my name's Ruth Crabtree. I'm the Public Health Lead for Yorkshire Ambulance Service. I also support the Association of Ambulance Chief Executives to think through kind of the role of the ambulance sector in public health and tackling health inequalities more broadly. So I'm just going to give a bit of the context and the journey that we've been on so far at that national level and kind of where we hope to develop work in the future. So if we could just have the next slide, please. Thank you. So I think the concept of public health within ambulance services isn't new, and I think it's increasingly being acknowledged and recognised that we do have an important role to play in improving population health. And all trusts are absolutely undertaking some work on prevention in some form, even if it isn't necessarily labelled as public health as such. But there hasn't really, up until fairly recently, been a kind of clearly defined model for what public health approaches look like within the sector, which has kind of often led to variation and stalling progress. And obviously we know we've had COVID in amongst all of that as well. So next slide, please. So just to give a bit of the history then, so back in 2017, a consensus statement was launched by ACE in collaboration with Public Health England, NHS England, Health Education England and other partners. Really, I guess, just to kind of describe that intent of all ambulance trusts to work more in collaboration around kind of improving health and wellbeing and taking that kind of more upstream approach. But I think it's fair to say that this was quite focused on kind of the role of public health approaches within our frontline activities, which is, you know, really important, and there's probably more that we can do around that. But it didn't necessarily recognise some of the stuff that Christine was talking about around kind of those wider determinants and working even further upstream. Obviously, as we know, the pandemic shone a huge light on health inequalities. And that was an opportunity, I think, to kind of almost restart the conversation and think about what that broader role in terms of implementing public health approaches and tackling health inequalities might be for the sector. So last year, we launched a discussion paper to start to articulate, I think, what those core public health approaches might look like, and how we can apply those to the sector. And as Christine said, we can pop the link to that in the chat for anybody who's not seen it. Next slide, please. Fabulous. So off the back of that paper, we decided to hold a round table event, which was really to start to explore that role in tackling health inequalities, but explore it with our key stakeholders as well, because obviously this isn't something that the sector can do on its own. So that was held on the 1st of February. It was really, really well attended, which was excellent. We had over 100 stakeholders attend the event, and it was chaired by Dr. Bola Olwalabi, who's the lead for health inequalities within the National NHS England team. And we also have Dr. Chris Grant, who's the medical director for NWAS, as our executive sponsor within the sector, which is great. So really we kind of used the event to sort of explore what the opportunities were, any potential barriers and actions that we can take collectively across the system to help embed this approach across the sector. And we had some really great discussions as part of the event. Next slide, please. So within the event, we touched on those two key themes that Christine's already outlined. So health inequalities in the context of access, experience and outcomes in healthcare. So that really relates to that core 20+5 framework and what the ambulance sector role is in relation to that. But then also that role in terms of tackling those wider determinants of health and our role as anchor organisations. So I won't talk any further about that because Christine's already kind of touched on that. Next slide, please. What we also talked about is some of those strategic enablers that we really need to think through as a sector to help support some of this work. So those were around strategic leadership and accountability, workforce development, both in terms of how we can bring public health expertise into trusts, but also how we can, I guess, upskill our workforce in terms of kind of understanding health inequalities, understanding what those wider determinants are, and kind of really bringing the workforce up to speed in terms of that. Data, evidence and evaluation, absolutely key in implementing public health approaches. And as Christine's already touched on, we've got a wealth of data that we're just not really using in this space. So how we can use that better, and then how we can use evaluation to support implementing further approaches and kind of really evidencing that benefit that we can bring to this agenda. And then partnerships, absolutely really, really key. Because we've got so much that we can contribute to this agenda. There are some pieces that we might want to do within trusts specifically, but actually there's a huge amount that we can contribute as part of that wider system. So it's exploring those partnerships as well and how we can add most value. Next slide, please. So one of the key recommendations that came out of that event was that we would revisit that 2017 consensus statement and really update that, reflecting this kind of shift in focus and gathering momentum towards kind of thinking even further upstream around those broader determinants of health, and think about so really update that consensus statement to think through where we best sit in terms of that space. Next slide, please. So we've had the first meeting of that consensus development group at the beginning of the month. So we had representation from all of the key stakeholders that were at the round table, and you can see those on the slide there. I guess the main purpose of that first event was just to kind of agree some key principles and the way that we want to work and develop this consensus statement. So absolutely we want that to be evidence-based and draw on what we already know, but think through if there are any gaps in the evidence base as well. Partnership and collaboration, really key. So making sure that we've got real joint ownership around this agenda. And then actually we do think through some of those barriers, and we think through how we can overcome some of those so that this really does embed sustainable change. So in terms of the next steps for what we want to do at a national level, so we're going to pull together what we know into, I guess, a kind of what we know document, and there's some potential areas of focus there on the slide. So where ambulance services could potentially really impact on health inequalities and health improvement. And that goes back to what we talked about in terms of access, experience, outcomes, the anchor organisations agenda, but also, what pathways of care have we got, what pathways of care might we want to implement, which can also really contribute to this agenda. Where the opportunities, the levers, the appetite is, and I think we probably know some of that, but there might be a little bit more exploration we could do around that. And again, the kind of preventing action and barriers to change, as I say, probably already know some of that, but there's perhaps a bit more that we can scope with our stakeholders around that. And then there is also some transferable learning from other sectors, as we know, from kind of the fire service and the police service as well. So what we're hoping is that we can get that what we know document ready for the Ambulance Leadership Forum in September, and that will hopefully form the backbone, I guess, of the recommendations that the consensus development group can then think through how we take those forwards and how we best work in partnership to do that. And that was it from me.
Thanks, Ruth. I'll open up to any questions. No, not just now. That's grand. So within that, both Christine and Ruth have touched on the importance of data and also of stakeholders. And next, we're going to have a number of colleagues from across the UK Ambulance Services present some of their engagement and some of the work that they've been doing, which will help with hopefully your thinking and ideas around what you can do within your environment. And it's with stakeholders, it actually depends on what you're trying to do. So actually, if you're looking to engage with and support vaccinating remote and rural community, then actually you probably just need to engage with the health board and engage with your governance processes internally to make sure that you've got that legal framework to be able to deliver that. And so your stakeholder engagement is quite small to deliver that sort of intervention. But actually, when I think about something that I saw the other week around delivering an out-of-hospital cardiac arrest strategy, the stakeholders within that are quite massive, but actually what they're looking to achieve is across the whole country and improving outcomes for people suffering out-of-hospital cardiac arrest within the community. And actually the work that they're doing in reaching out to that, to some of the communities means that you've got to get right down to that granular level and link with leaders within those local communities, as well as Scottish Government, the ambulance service, police, fire brigade, and education to reach as far as they're looking to within that strategy. And then throughout the presentations, hopefully you'll see the importance of data as well, and that will enable you to find your focus or map where you are just now as well. And without further ado, I'm going to hand over to Lauren from the Scottish Ambulance Service.
Thanks, Andrew. Are you in charge of my slides? Yeah, thank you. So morning, everyone. I'm Lauren Sloy. I am the Clinical Effectiveness Lead of Drug Harms for the Scottish Ambulance Service in the West of Scotland region. My colleagues Mary Monroe, who is the same role in the North of Scotland, and Julie McCartney, who manages the East of Scotland, again in the same role, are all a part of the team that I work within alongside our Senior Outcomes Analyst, Abby McQueen. And I'd just like to sort of note that our appointment to the ambulance service, albeit individuals not from the ambulance service originally, really is a measure of the commitment of the ambulance service to reducing the inequalities that we see marked within drug deaths. Just on the bottom left there is at HarmLead's Twitter, that's the team's Twitter if you do want to communicate with any one of us from a national perspective. Can you pop on to the next slide, please, Andrew? So to start, I really just wanted to remind everyone of the Scottish context of drug-related deaths, because obviously it is significantly different to anywhere else in the UK. And this is ultimately the reason that the ambulance service took on this role, to understand how to utilise its unique reach into communities that allows that kind of consistent engagement with individuals branded as hard to reach, so that we can offer those individuals linkage to community-based harm reduction and to coordinated care. And obviously Christine kind of set the scene for us on what Scottish Index of Multiple Deprivation might look like. And so very similar to the areas that were talked about earlier within Scotland, we see people very much more at risk if they're living in the areas of higher deprivation. Next slide, please, Andrew. So as I mentioned, the ambulance service took on 3 full-time clinical effectiveness leads and an outcomes analyst. But the first part of our mission was really to embed the supply of take-home naloxone to all individuals at risk of either witnessing or experiencing an overdose, just as a part of everyday practice for clinicians. Now, extensive training's gone on over the last year, but on the graph we can actually see the result of that, and this is the figures of the kits that have been supplied to individuals at risk up until March of this year. What's really interesting though is a deeper dive into that information to understand who received a kit and why. And this piece of information was allowing us to see that not only was the ambulance service equipping 1,276 family members of individuals who use substances and individuals who use substances themselves to allow them to respond to overdose, but that actually 63% of that total figure were individuals who had never had access to naloxone from any other service before. This was the first time that they had been offered it. So this is really meaning that the ambulance services do see a huge number of people who are at risk of a preventable death who just may not have access to life-saving medication from anywhere else. Next slide, please. So beyond the provision of the life-saving medication, which we all know in the chain of survival, very much best situated in the community, we do also know the importance of breaking the cycle of health harm behaviour. And to do this, we needed to communicate with health board partners, alcohol and drug group partnerships, third sector partners, a whole range of services to try and understand how we can communicate with them to initiate this kind of chain of response where an individual was going to have outreach into the community after the experience of an overdose. So the graph on your screen represents the figures of referrals that have been achieved by the National Overdose Response Pathway that's been developed in partnership with health boards. And we're now able to communicate every single incident of overdose, as I say, initiating that chain of response that takes the care to the patient where they are comfortable engaging with us. And of the 5,757 incidents reported in this pathway between July 2021 and March 2022, that represents individuals who consented to the connection to services following an accidental illicit drug overdose. And this is showing us that people do want help. If they are asked about accessing help in the community, they are saying yes, and we just need to be able to approach them and have that access to that for them. Next slide, please. So on this side, it's just a bit of a further breakdown of those referrals just into different regions. The orange section is indicating the percentage of individuals who were not active on community addiction caseloads at the time of the data sharing, so meaning no access to specialist addiction support. And we found nationally an average of 45% of the 5,757 cases referred were not open to specialist support at the time of the emergency care interaction. So if we just take one of the examples from the screen here, the East Region, Forth Valley, what that's telling us is that 47% of 236 individuals were not active on community caseloads. So this allowed us to coordinate their need for care. And while 53% were active on caseloads, it allowed us to still make that communication to say there are other risks going on that you may not be aware of. Can we ensure that there is some kind of follow-up around medical or social care needs reviews for these individuals? Next slide, please. So beyond the direct connection pathway, we use data in other ways. And this is just a small example of how we communicate trends analysis to partners. So trends analysis currently shows things like high risk times of day, day of week, month of year, and high risk postcodes for near fatal overdose incidents. And while some of that information was previously routinely provided by A&E departments to the same partners, the ambulance service provides a much wider picture of trends by including incidents experienced by the individuals who were not conveyed to hospital and who may never have been known to A&E services. There is another addition as well, whereby the ambulance service can use things like incident postcode versus the home postcode of the patient to understand patterns of travelling to city centres where public injecting and the associated risks are very high. So this has allowed the ambulance service to support some long-held hypotheses about the causes of public injecting. And trends data has been further translated into regional resource allocation, which allows our partners to sort of respond to the service needs and the identified gaps shown by the hotspot mapping, and by allowing them to analyse what happens in their regions during the high-risk days, times and months to begin a deeper analysis of behaviour. And my last slide, please. So this is really just a bit of a representation of the future. I'm not expecting you to have a wee read through it all, but basically on the left-hand side is a representation of how we currently use data flags to identify the individuals that we want to connect to support through the overdose pathway. It's working really well, but for it to work very well, we have to wait for individuals to experience an overdose. And so because of that, we recognise that the ambulance service hasn't really yet shown its true potential in the early identification of individuals who are at risk of death from overdose. And on the right-hand column, we can see our very much work in progress definition that we hope to use in the near future to identify individuals for that same coordinated, assertive community response, but before harm takes place. So in developing that definition, we work alongside our partners again with drug death associate researchers. And it's to ensure that we're thinking about drug death risk stratification that helps us understand how individuals who experience multiple complex needs actually interact with emergency care on the lead up to fatal incidents. Now, while every one of those preventable deaths is a real failure, SAS is able to harness the learning from each death and use that knowledge to optimise the future of this early and identification pathway that considers not just the harm already caused, but the cumulative multiple complex needs risk factors. And so that is me. I will pass back to Andrew if we are facilitating some questions at the moment.
Thanks, Lauren. We'll just hand over to Christine and then we'll pause for some questions from either after that.
Thank you. So I'm just going to pick up from when I was talking about the Core 20+5 framework earlier and just give an example of some pilot work that we started to do around hypertension case finding. Yes, if you could just, thank you. So this is just a bit of the background. So there's modelling that has been done around undiagnosed hypertension, and that estimates that there's over 500,000 people in the northwest of England with undiagnosed hypertension. And as an organisation, we take blood pressure readings from over 1 million people every year. And I'm sure the trust will be doing similar volumes to that as well, other ambulance trusts. Now, last year, we started using an electronic patient record for the first time. And I know Lauren had a lot to fit in her slot, but I think she's undersold the really sophisticated data that they have up there in Scotland. So we don't have anything like that in the Northwest. But we wanted to make the most of this new electronic patient record and look at the blood pressure data that we have and think about that at a population level. And so we ran a pilot with a primary care network, which is a collection of GP practices. And these slides are just talking about what happened in that pilot. Okay, so if you could just move on for me, please. Right, there's a lot of writing on here, isn't there? But basically, just to let you know what we did is we took 2 months worth of data and we took out any children, anyone who was conveyed to hospital, anyone who didn't have complete blood pressure data. We took out some of the clinical impressions, so people who were recorded as being dead on arrival or were receiving terminal care. And then we used a cutoff of 140/90 as people as having high blood pressure. And then we picked out that sample of people and sent the ones that were from this particular primary care network, which was 8 GP practices. We sent that data over to them, linked with the NHS number so that they could then look those individuals up in their systems. And what we asked them to do was to contact all of the people on that list and to take their blood pressure in primary care. And we didn't kind of specify anything further than that. So that could have been done in pharmacies, it could have been done by healthcare assistants, it's whatever structures they had set up. This particular primary care network had hypertension clinics set up. So a lot of the people went into that structure. And then we asked them to send the data back to us. They didn't send us any names or in fact any blood pressure readings. We just kind of collated what happened. And I think the next slide actually shows the information that we asked for them to send back to us. Yeah, more or less. So it was basically just numbers. So we said to them, you know, we gave you this number of patients, what happened with them as they went through the system. So really just trying to keep that data collection as simple as possible. Yeah, next slide, please. Okay, so this just kind of gives an overview of what we found out from that. that particular pilot. So there were 71 patients that we transferred to them after we'd done all of those exclusions. And of those, it was about half and half that they were able to contact in primary care. And the ones they weren't able to contact, it was a combination of they couldn't find them on the GP system, or just no one answered the phone after several attempts, or they were people who were in care homes, or they were deceased, or they had declined to actually come for an appointment in primary care. But that was only quite a small number. Of the people they were able to contact, I think actually everyone did come for an appointment. So what we found from that is, so from the cohort of 35 people who came and had an appointment in primary care, there were 6 new diagnoses of hypertension. There were 4 people who had borderline high blood pressure who were referred for lifestyle interventions. There were 4 people who had an existing diagnosis of hypertension and they had changes to their management. And the remaining 21 people, their blood pressure was normal when it was taken in primary care, so there was no further follow-up. And the speech bubbles on the right is some of the feedback that we had from that primary care network. We weren't really sure, I suppose, how it would be received, whether it would be seen as a lot of extra work, but they were kind of very positive about it. They felt that it was really worthwhile, and that this is kind of data and information they wouldn't have got from anywhere else, and that they wouldn't have had any other way of actually identifying these patients. So it's quite positive in that sense. Have I got another slide, Andrew? Oh yeah. So we're aware that this is a really small pilot. So we actually cover 5 integrated care systems in the Northwest, 3 main ones, and then bits of 2 other ones. So we want to do this in at least 2 more areas. I mentioned ethnicity data before. That was an issue again in this pilot when we looked at that over the whole population. But again, we could repeat this over a longer period of time to try and understand what that hypertension data looks like at a population level. Do we have particular areas where quite a high proportion of people that are actually coming through the service have high blood pressure, that we might want to feed that back for some local work? And again, as Andrew kind of mentioned in his introduction, this is about both data but also about partnerships. So we can use our data to try and identify some of these areas of need, but then addressing that requires working in partnership with the wider system. And there are developments around shared care records that would allow the more routine sharing of all this information with primary care. Again, we're not there yet, but we want to try and do some of this work to try and make that case to primary care that actually ambulance service data can be useful for this work. So I think that's it from me. Yep, perfect, thank you.
Thanks, Christine. Just looking to see if there's any questions in the chat. If anyone wants to put their hand up and ask any questions of Lauren or Christine, feel free just now. David?
Yeah, thanks, Andrew. I think it's just a question around the data for Christine. Obviously, a lot of the work that's identified in the core 20+5, we should already have quite a lot of information. Have you found that you're able to pull some historic stuff as well, or have you had to sort of start, unfortunately, from scratch because you're needing slightly different information? I'm just thinking, if from our perspective, if we're going to jump in with this, which we absolutely need to, is there anything that we need to start getting ready now so that we can put a data request in, or as I say, were you able to get some of the information that was useful without us even knowing that we needed it, if that makes sense?
Yeah, I think so. I mean, I think certainly the blood pressure data, if your organisation is using an electronic patient record, you will be recording that information already. I think if you want to understand what that looks like at a population level, it's more about, I suppose, how you analyse that data and other data sources that you might want to link it to as well. So I think there's a lot of data there. It's more kind of how it's analysed. And I suppose my experience in our organisation is that we have a lot of, so for example, we have these Power BI dashboards. So we've got a falls dashboard, for example, and that will tell you the number of falls incidents within each of our sectors. But it's not that data isn't expressed as rates. So you can't actually compare between sectors, because the sector with the biggest population will have the most falls. And the data isn't broken down by ethnicity or deprivation. So if there was a question around that, you can't answer it from the way the data is presented. So I think sometimes it's maybe that we're asking slightly different questions of the data that already exists, if that makes sense.
Yeah, so it does, yeah. And so I think we just need to be a little bit clearer in the collection from the staff that with these patients to absolutely ensure that we're getting everything that we're able to with the patient, so that we can then, when we need to interrogate it from a bigger, wider perspective, we've actually got it. So yeah, no, that's really helpful.
That's a really good point. And just really quickly, one example of that. So when we started to have conversations with primary care on this blood pressure data, we often get asked, what about AF? Can you tell us about anyone with AF as well? And unfortunately for us, the answer is no, because although everyone will get a pulse check, if AF was detected, there isn't actually anywhere in our electronic patient record like a box that you would tick that would say yes, no. So someone might write something in free text, but then when you look at trying to pull that out over like millions of incidents, that's then going to be really unreliable. But we could be doing more in terms of detection of AF if we're thinking about stroke prevention. So you're absolutely right. Your point about, that needs to be set up in the electronic patient record in a way that it can be easily captured, as opposed to being free text or whatever else.
Thanks both. Is there any more questions for either Laura and Christine just now? No, I'm going to see if I can do a better job of sharing my screen again this time. And I'm going to pass over to David, who's going to share some work across COVID.
Yeah, thanks, Andrew. So just to sort of set the context very quickly, as we went into the very early stages of being aware of COVID, so even sort of before, we started to discuss what that might mean to our frequent callers. So there is a link between our frequent callers and their mental ill health sometimes. So the approach that we were, the thing that we were really scared of was that we were just going to be inundated with callers whose anxiety was raised even higher, and the prediction potentially was that this could really overwhelm or make the system so much more difficult to manage because of the volume. So actually, we looked at this from day one, and as I say, on average, there was 4 new callers to the system every month to 999. This is using our frequent caller criteria, but very quickly in the first month of lockdown, this increased to 17 new callers, which between them had generated 250 calls in the first month. Now, interestingly, the frequent callers that we had on our database up until that point, they dropped off. So the frequent callers that we thought we were going to have an issue with supporting as best as we could, they disappeared. But this new level of, we can only call it an anxiety sort of based reason for calling, it increased, and we were very worried, as I say, that if there's 17 people with 250 calls, that was really potentially quite high. Next slide, Andrew, please. So as I say, that the concern was this 250% increase, and the other side, apart from our ability to respond to everybody in a timely manner, was that, as we all know, these people, if we don't get them signposted correctly, or we don't get them signposted as quickly as we can, they just end up stuck in a loop. We'll send an ambulance, we'll go, or somebody will speak to them and they'll be fine, and then they'll ring again and we'll go, and we unfortunately create that cycle ourselves. So what we decided to do is to use this similar approach we use with our normal frequent callers, and got really quickly into these this new cohort of patients, GP or GPs. So we contacted the GPs, just changed the wording of the letter that we normally use. So it wasn't anything that was unbelievably, it wasn't a massive innovation. It was just actually stealing what we already found worked with our current cohort, with this new cohort. And actually the response from primary care was fantastic. And I think that with that co-working and the way that we address this in a timely manner, it all helped to actually get the end result, which, Andrew, if you wanted just to go to the there is much more detail on this, which will absolutely be available if anybody's interested. But again, the whole reason for Ambulance Q is, we can start to share these things out. So at the end of the first month after we sent the letters, everybody that had become identified as one of these new frequent callers had stopped ringing, which we were blown away by, and thankfully we didn't have people that were stuck in that system with not knowing where to go. So we did a little bit of data analysis around what that time was and what the saving was, and as you can see on there, that initially we had the potential of 100 and odd hours that was spent with these patients. And after our intervention, there was a massive reduction, both in number of contacts, in the time on scene, the cost of the service. The reason that was in is we were talking to the CCG around what we did in COVID. So I left that in because sometimes cost or the ability to put money back into the system is quite an important piece of data. But for me, it was the fact that we managed to identify a group which were genuinely and not surprisingly worried, concerned, anxious. Obviously, all of the we did want to map this against the press releases in regards to the lockdown and how the lockdown changed and it got more severe, because it was only at the point of the lockdown that these this cohort became or came onto our radar. So there was an interesting sort of socio inequalities thing. What we didn't then drill down and say and ask those people, what is it that actually made you want to reach out to 111 or 999? Is it because you didn't want to bother with your GP, or you thought it was too busy, or you were really absolutely petrified to leave the house, even under the conditions that were laid under. So we didn't get a chance to do that bit, and that's probably the only reflection, which I think would have been nice to get to the bottom of. But yeah, we regardless of that, I thought we did a pretty good job. And hopefully, if anybody is interested, we can share those details out further. Happy to take any questions, Andrew.
Thanks, David. We'll go across to Lewis and then Sandra, and we'll pause for questions again at the end. So I will hand over to Lewis from Yorkshire.
Morning, everyone. I'm Lewis Torrey. I'm the Community Engagement Lead for Yorkshire Ambulance Service. Been with Yaz about 9 months now. So fairly new to the organisation, new to the sector. I was working in commissioning and with the ICSs before that, and in local government before that. So Ruth asked me this morning if I could talk for 5 minutes. So you have to bear with me. I've quite hastily cobbled together a presentation, which I'm going to share. Not use Zoom for a while. Can everybody see that? Yeah, okay, brill. So normally when I talk about health inequalities and community engagement at Yaz, I talk through our community engagement strategy. So I joined in August, and then we launched a new strategy for community engagement in November that's very much focused on using community engagement as a tool to try and address health inequalities. But I won't talk through the strategy. What I will do instead is just talk about what we kind of set out at the back end of last year, the last calendar year, is the areas that we think we need to develop in to be aligned with the community engagement strategy that's focused on health inequality. So there's something about who we work with. So the baseline we were working from was quite reactive community engagement work. So going and talking to the communities that were approaching us. So we need to move to proactively prioritising different populations. We need to be aligned with partners on who those populations are, and targeting in line with what the evidence tells us we should be doing and who we should be working with to address health inequalities. There's something about where we work geographically. Some of this we are doing. So we are being more proactive about which geographies or neighbourhoods we work with, using the core 20+5. Stuff that's more ambitious that we won't do now, but we want to do over the 3 years that our strategy covers. So starting to channel more of the wider Yaz resource into neighbourhoods. So if we're doing a lot of community engagement in a specific area, bringing in things like volunteer programmes, DFID programmes, getting the Yaz charity to work in those areas, and then ultimately doing that with our partners as well. So where we know system partners are focused on specific neighbourhoods, seeing what the Yaz role is in that, so working in more of a community development way. At the bottom left there's definitely something in what we deliver. So our core traditionally has been training and education, so training, education around life-saving skills. So we're starting to broaden that, starting to look at things like employability as a wider determinant of health. So we have been working in that space before, mainly careers fairs for colleges and schools. So moving away from that and starting to do more kind of targeted engagement programs just to try and get people into work, and then ultimately try and do some more upstream preventative work. There's something in how we work. So trying to make more use of the assets we've got at Yaz, whether that's our buildings, our staff, our volunteers, 6,000 staff, nearly 1,000 volunteers. So we're kind of very visible, and we are out engaging and interacting with our communities. But as a community engagement team, we don't necessarily pull all that resource together, and then trying to move to facilitating and empowering other people. So we do a lot of training delivery. We're a small team. What we're trying to move to is putting those training skills into communities. So that's kind of a map of where we think we need to go. So some of that stuff is quite long term for us. Some of it we're doing now. So in terms of where we want to start for this year, we're prioritising engagement with inclusion health groups and vulnerable communities, and we're working with homeless communities and people with a learning disability in the first instance. So that's two things really. It's targeting some of our core training education delivery for those communities, but it's also trying to work towards a broader objective. So that kind of lengthy objective at the bottom of the slide is from our community engagement strategy, which is just about being responsive to our communities. So engaging, trying to understand and respond to the needs of people who've got different experiences of our services, particularly those who are vulnerable. So it's about relationship building, it's about understanding. And I think for Yaz and probably a lot of other ambulance trusts, we're starting from a place where we don't necessarily know as much as other organisations in the systems know about how people use their services. So we're starting from a low insight base. So it's a good place for community engagement to start, to try and get some of that insight just through conversations. In terms of putting that together, we're working with 3 ICSs across our patch to try and commission a programme through the voluntary sector. So working with either one lead provider or an alliance of organisations that are known and trusted in the communities we want to work with. 2 broad objectives for that work: understanding experience, understanding access, understanding barriers, and then trying to explore are there other things that Yaz can do outside of our core emergency role that complements what the wider system is doing and kind of fits with Yaz as well. Why start here? So I suppose for us, as I said, we have got an insight gap in understanding how different populations are using us, how they're interacting with us, what the barriers are, what their experience is. There's obviously a growing national body of evidence on inclusion health groups of vulnerable populations and their health and care access. And there are bits of really good local engagement that the wider systems have done. I suppose the problem for Yaz is that wider system work, that wider system community engagement, it tends to be quite heavily focused on primary, community and secondary care, because that's where the main touch points are for most populations. And you get very little on experience of the ambulance service, but you can assume that if you're talking about homeless populations or people with a learning disability, not only do they have the worst health outcomes, but they're going to have a very different experience of ambulance services as well. I think for us at a basic level, it's just an opportunity to build some relationships with communities, with stakeholders, with the voluntary sector as well, and just to start a conversation. So we have to start somewhere. This is a really good place for us to start. In terms of scoping it, so this is part of the briefing that we sent to our ICS partners, just to kind of tell them what we want to do and how we want to do it. So this is the first bit. So we're working with communities that we know have got poor health outcomes, face barriers to access, differential experience, align with the core 20+5 framework. We do this work without the framework, but it's a useful reference point for us as well. We want to work with communities that are also aligned to the communities that our wider system partners want to work with, and communities that we think we can work with to explore other things that Yaz can do outside of our core emergency response role. We don't know what those things are. It's something that we struggle with as a service, so not knowing where we might get to with the engagement is difficult for the organisation. But we've just got to kind of get out there and talk to people and see if there is a wider role for us. So we're kind of starting with that work. We're doing other things as well, other things in the space of health inequalities. Some kind of caveats, I suppose. Firstly, community engagement is one piece of a much larger effort that Yaz is starting to make on health inequalities. We've got a wider piece of work looking at what the whole organisation can do. And there's pockets of the organisation that are doing this kind of work, but we're not necessarily brought together and pointing in the same direction. So we need to do some of that work. This is new for us as a community engagement team. This kind of stuff won't be new to people in other sectors, but it's definitely new for us. So we are taking quite a lot of time to scope it. The main reason for that is once we start talking to communities, you open the conversation and there's immediately an expectation there, rightfully, an expectation that you're going to follow that through and do something. So we need to get it right. We need to make sure it's aligned with the work the system wants us to do and that Yaz are behind us, so that as we start to kind of hopefully draw some insights together, we can actually do some work. The engagement's just the insight gathering, it's the work that comes after that's really important, and that kind of leads into the next point. It's about relationship building over quick wins. So everyone likes to see quick wins. I think we've started to talk just about things to do first rather than quick wins, because none of this is quick. It's really good to see in the new guidance on engagement from NHSEI, they are starting to talk about more dialogue-based engagement, longer term relationship building, which is all really positive stuff. And then the last point there, we've got to start somewhere. So we don't have a really solid evidence base for where Yaz should focus its work. There's some national evidence, but there's something in just starting. So system partners are asking why homeless communities and why people with learning disability. And I suppose the answer is, why not? we could start in a number of places in terms of who we want to work with. Their communities that we know have really poor health outcomes, we can assume they've got a different experience of our service. System partners are working in the same space, so they are good places to start. So yeah, I mean, it is community engagement. It isn't necessarily the whole of YAS, but I think for me, this is kind of a route in. So if community engagement is kind of going through the keyhole, we can open up the door as we start to get the insight coming through, and then it will need to be a whole YAS thing. So I don't know what the question ordering is, so I'll stop sharing and pause. I've not had to stop sharing on Zoom for quite some time. Oh, there it is.
Thanks, Lewis. I'm quite happy to pause. There was a couple of questions just there before we hand over to Sandra for our last presentation. So has anyone got any questions? There's one in the chat around for Lewis. And Lewis, what do you think is needed to plug that insight gap that you spoke about?
Yeah, it's really easy for me to answer that because I don't know. So kind of reflective of where I was at in my last role when I worked with an ICS, where there was a focus on starting to be a focus on health inequalities, but the system kind of told us as community engagement people who to work with. There was an existing framework that organisations were around, and we don't have that at YAS. So when I came here, the message is loud and clear. We want to be focused on health inequalities. There's tons of enthusiasm to do it. People really want to do it. They're really into it. But there's no kind of starting reference point. So I don't know. I can only say what I know as a community engagement person, which is we don't have any service data that can tell me who's using what, when they're using it, and how they're using it. There's no kind of history of ongoing dialogue with different communities, so we can kind of pick up issues and what's the history of work with this community or that community. It just isn't there. So I think for me, and I don't want to pass the buck, probably a little bit, the community engagement contribution is to start that conversation. So let's start talking to some of our communities and see what comes back. And when I took the strategy through the board and the organisation, we're really clear that the message to the team is, yeah, focus on health inequalities. The message for the team back to the organisation is, yes, but we need a wider piece that wraps around that. Community engagement on its own is just about trying to build some relationships. So that's a kind of long way of saying I don't know, I suppose, isn't it?
And then there's another question about that wider thing. Do you have context with other community engagement leads in the other ambulance trusts?
We do, services? Yeah. So we're connected with LAS. So they're doing a lot of work. They're in a different place to us. They've done some of the stuff that we want to do. So we're connected with them. We've had some conversations with MWAS as well, because we're really interested in the work they do on widening participation. So we've got an objective in our community engagement strategy that's about what we can do as an anchor organisation, and specifically focusing for community engagement on employability. I think I just briefly mentioned that the work the team has done in this space in the past is good work, but it tends to be responding to requests for us to go to talk about opportunities to work for YAS. So do you want to be a paramedic? Uniform Services College, do you want to be a paramedic? Well, those people work for us if they want to work for us. They haven't, it's a decision-making thing for them. Where we're starting to focus the work is people who wouldn't see themselves as working for us, but could do, because we've got such a wide breadth of roles available. It's one of the only places you can work a kind of entry-level job and have a good job with a contract and annual leave and maternity leave and sick pay and all the other stuff. And then also just trying to get YAS to focus on employment as a wider determinant. So it's not just all about getting people into YAS, it's about getting people into work. And MWAS are doing some really good stuff in that space. I think there is a network of community engagement people for the ambulance sector, but we haven't found it yet. So if anyone's found it, then you can point us in the right direction.
Fair enough. Okay, thank you. And there's a few nuggets you might want to have a look at in the chat there as well. Grand. So I will share my screen, Sandra, and I'll hand over to you.
Great, thanks, Andy. Brilliant, thank you. Morning, everyone. So I'm Sandra James. I'm a consultant in public health in the East of England. I'm actually employed by the Office for Health Improvement and Disparities, which sits within the Department of Health. So we are essentially the health and wellbeing component of what was previously Public Health England until October of last year. So we've been working really closely with the East of England Ambulance Service for about, it was pre-COVID, so a while now, just supporting them really, you know, from a partnership perspective, I suppose, around their kind of journey with the whole public health prevention and inequalities work. So I'm just going to talk very briefly this morning about the Inequalities Board that we've recently established at East. So the first question is, why now? Why have we decided that an Inequalities Board is a good thing to set up at this point in time? I think Ruth alluded to earlier this morning the fact that there is this growing national conversation around the role of the ambulance sector. Both in improving population health outcomes, but also the role that the sector can play in driving down inequalities. And that's, you know, all of the fabulous work we've been hearing about this morning. So there is that growing sense of conversation around this. Again, it's already been mentioned this morning, the COVID-19 pandemic has just, you know, highlighted stark inequalities that exist in our populations. And on the back of that, we've seen the NHS launch what is their approach to reducing inequalities, the Core 20+5 model. And so really there's no better time, I think, to be having these conversations around inequalities. And alongside this, we've recently finalised our public health and prevention strategy. So that is, I'm not going to go through it this morning, but it's quite a high level, ambitious strategy which really sets out the direction that the Trust wants to go in terms of applying public health approaches to its work. So looking at things through a population lens, better utilisation of the data, and again, that's been talked about a lot this morning, having that focus on driving down inequalities and focusing on upstream prevention, making sure that the Trust is evidence-based in all that it does, and then a strong emphasis on working with system partners. Next slide, please. Thank you. So the next question then, that kind of sets the scene about why we thought this was a good time, but why an Inequalities Board specifically? Well, now that we've got the public health and prevention strategy drafted, there is a general recognition across the Trust that there's lots of pockets of work going on, as is likely to be the case in all trusts across the country, but it's not necessarily recognised as you know, being upstream prevention work, or not necessarily looked at through the lens of how could this impact on health inequalities. So what we want this board to do is provide that strategic platform of oversight. So almost that umbrella within the Trust that we can begin to draw things under, and we can provide additional direction and also look at how we're monitoring progress and demonstrating the impact that the Trust is having. Having this as an internal board is also a mechanism for raising the profile of the inequalities agenda within the Trust. So having that kind of senior leadership buy-in and having this at board level gives it that weight behind it. And it also, we hope, is going to support the narrative within the Trust that addressing inequalities is everybody's business. So we talk a lot, you know, in all areas of health and social care about inequalities being everybody's business, and it really is. But we just feel as though that kind of board which has oversight of this thread of work is going to be really helpful in ensuring that it is kind of knitted into the fabric of the organisation. Next slide, please. So setting up our Inequalities Board, it's currently being chaired by our Chief Operating Officer, with myself currently as co-chair. We have support for the functioning of the board, which comes from the Programme Management Office. We have terms of reference, which outline obviously the aims of the board and the membership. And the next step really is in looking at a delivery plan to support the implementation of the strategy. Next slide, please. what I've pulled out here is some of our kind of key aims for our inequalities board. So it's about embedding public health approaches within the organisation and developing that infrastructure, which is really going to set the direction of travel in terms of those elements that I talked about within our kind of high level strategy. So teasing out how the organisation is going to improve its use of data to look at inequalities and prevention, looking at other issues around workforce development and training, and then looking at taking a project delivery approach to pieces of work where we know they're having an impact on health inequalities. The board will help to support the delivery of the strategy ultimately. It's going to give us a platform to look at other kind of relevant strategies which exist in the region in partnership with our integrated care systems. It's going to again, set the direction of travel in terms of informing evidence-based practice. It's going to give us that strategic governance framework, and it's also going to allow us to sort of work alongside our workforce development colleagues around planning and development of staff. So I think that's probably it. The next step on our journey, we've actually only had one board meeting, but colleagues on the call thought it would still be useful to bring it to this meeting just to share, even though we're early on in the journey. So we've had our initial board meeting and the second one is scheduled for July. And I think our next order of business is going to be undertaking some mapping across the trust to identify almost, I suppose, what the low-hanging fruit is. So, you know, what are the pieces of work that are already going on where we could add value in terms of prevention and inequalities, and then where we've got, you know, gaps that are going to need some slightly more strategic planning in terms of how do we meet those, and it might be additional resourcing is needed and business cases, etc. So I'll leave it there. I'm happy to pick up any questions or discuss further. Thanks, Andy.
Thanks, Sandra. Chris, do you want to ask your question?
Yes, good morning and hi everyone. My question was about the board and the membership. Are there any, or will there be, recruitment of public members, lay members, probably from those communities, groups with protected characteristics that have lived or living experience of, you know, fewer opportunities to access services and thus are unequally served? That was something.
Yeah, thanks, Chris. That's a fantastic question, and that's actually a conversation that we did start to touch on. As I said, we've only had our first board meeting. At the moment, the membership is for internal trust colleagues from across the organisation in various different departments. But absolutely, I think further down the line, that is something that we will be looking into. How do we engage? And I was, you know, really interested to hear Lewis's previous presentation about the community engagement aspect. So in answer to your question, we don't currently have any public representation on the board, but that's not to say that we won't have going forwards.
No offense, but this is striking. This, you know, is something like a prerequisite to help achieve the set objectives and aims. And I wish to believe from my membership with Q and other initiatives that this is more than obvious, no? I mean, if you want to tackle inequalities and health inequalities, you work from the very beginning with those affected, those that have lived experiences that they know, and they can provide with local knowledge and insight.
Yes, I don't disagree with you at all, Chris. I don't disagree with what you're saying. I absolutely, you know, do recognise the importance of that. Yeah, user engagement, community engagement, absolutely.
Thank you both. Is there any other questions? I didn't see any other in the chat or, oh, Christine.
Yeah, so I just want to add to that I think the model the model that Sandra just described in the east of England is a really good thing for other ambulance trusts to think about in terms of how will they get some of that public health expertise in their trust. And I think there's lots of different ways around that, but it's one of the things that we've identified at a national level that I suppose it's a barrier of actually ambulance trusts not necessarily having that public health expertise within their organisations. And there's different ways that you can go around that. But every region will have public health consultants like Sandra, both in OHID and also in NHS England. So one route is to actually employ public health consultants directly in an ambulance trust. Another route is to engage in those existing structures in OHID and NHS England to try and bring some of that expertise into the organisation. So I think it's a really good example of a way to do some of that engagement.
Thanks, Christine. Right, I'm just going to, oh, can't see any other hands. So today we were hoping is just to share some insight as well. So the Welsh Ambulance Service were going to speak to us today about social prescribing, but we will need to look to engage with them at another time, and also London around anchor organisations. But if you were looking to talk to someone about that in a bit more detail, let us know and we can link you with them. And so we're going to spend the last 25 minutes